Hello, very good afternoon, everybody. Today we are going to talk about the second session of your pharmacology and a part of your PSM. Today we are going to talk about the second session of your pharmacology and the part of your PSM. So speaking about that, let me put on here. Let me put on the autocoids. So speaking about the autocoids, before I want to begin you with the autocoids, I want whomsoever present is to acknowledge faster that if you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. Okay. Okay, speaking about today's session, people, today we are going to talk about the autocoids. So autocoids, basically autocoids are classified into three types, people. What are they? One is a amine one, lipid one, and peptide one. Amine one, lipid one, and peptide one. Amine autocoids are histamine and serotonin, while lipid ones are prostaglandins, leukotrienes, and PAF, while peptide ones are bradykinin and angiotensin. Bradykinin and angiotensin. So first we talk about the histamine, then we talk about serotonin, then we talk about prostaglandins and leukotrienes. Okay. So speaking about the histamine, so what are the major source of your histamine, people? As we said, it is one of the important MCQ. The major source of your histamine is mast cells, people. The major source of your histamine is mast cells and acts on H1 and H2 receptor and acts on H1 and H2 receptors. Okay, and what are the functions of your histamine? So first one is the functions of your histamine. The main function of your histamine is production of vasodilation and increase in vascular permeability, contraction of visceral smooth muscle, increases gastric acid secretion. As we studied in our physiology, gastric acid secretion is regulated by three factors. One is by a hormonal, by your gastrin, neuronal by your vagus nerve, that is your acetylcholine. Then you know that gastric acid is increased by your histamine, by your paracranial regulation. So histamine can also increase your gastric acid secretion, and it will also maintain the wakefulness by activating your reticular activating system. Now speaking about that, so histamine receptors are basically classified as H1 and H2 receptors. So H1 receptors are mediated for your allergy and inflammation. H1 receptors are mediated for your allergy and inflammation, while H2 receptors are mediating for your acid production in the stomach. Acid production in the stomach. So we are having the antihistamines, which are considered to be the first generation and the second generation antihistamines, where first generation is both can block both your acetylcholine and the H1 receptor, while second generation antihistamines will block only the H1 receptor. So acetylcholine and H1 receptor blocking activity is shown by first generation, while second generation shows only the H1 receptor, and first generation can cross the BBB while second cannot able to cross the BBB. Okay, fine. So what are the drugs which belongs to first generation and second generation? Here are the important MCQ. So for the first generation, the important ones are your promethazine, diphenhydramine, and phenyramine. Promethazine, diphenhydramine, and phenyramine. While the second generation are cetirizine, which is causing a sedation in some patients, and terfenadine, fexofenadine, which is the fastest acting one, astamizole, which is the longest acting one, and loratadine is the another one which we uses for the second generation antihistamines, which is used for the treatment of allergy and inflammation on various areas. So the main one is your first generation promethazine, diphenhydramine, and phenyramine, while second generation ones are your cetirizine, terfenadine, fexofenadine, and astamizole and loratadine. Okay, astamizole and loratadine. Among that, fexofenadine is the fastest acting one. Among that, fexofenadine is the fastest acting one, and it can selectively blocks your H1 receptor. And this one, first generation, block both your H1 receptor as well as acetylcholine receptors. Okay, while H2 receptor blockers, we studied that in the case of your gastric acid secretion, ranitidine, famotidine, cloxetidine, noxetidine, all those things, cimetidine, and all those things, we will study that in the gastric acid secretion. Okay, now speaking about serotonin, All serotonin receptors are G protein coupled receptor except 5-HT3, which is a ion channel receptor. Very important MCQ. All serotonin receptors are G protein coupled receptor and except 5-HT3, which is a ion channel receptor. And types of receptor category, we can able to say like 5-HT1 to 5-HT4. 5-HT1, 1A and 1BRD will be there. 1A and 1BRD, the drugs belongs to the category of 5-HT1A is buspirone and gepredone. Okay, buspirone and gepredone is used for the treatment of anxiety, and 1BRD, sumatriptan, naratriptan, and provotriptan. All the triptans, okay, all the triptans which is used for the treatment of your migraine. And apart from that, 5-HT2A or 2C inhibitors are like your methyl sergate, ketenserin, and retenserin. So all the serins are 5-H2A or 2C inhibitors, which their receptors are present in the blood vessel. Activation could reach to increase in BP, while inactivation could lead to decrease in BP. Inactivation could lead to decrease in BP. So 5-HT1A analogs for anxiety. 1BRD analogs, which is all the triptans, which is used for the treatment of migraine. While 5-HT2A or 2C inhibitors like methyl sergate and ketenserin and retenserin and all, which is used for the treatment or regulation of your BP. Now third, 5-HT, 5-HT3 stimulators can trigger the chemo trigger zone and causes of vomiting, while blockers is such as an anti-emetics. So anything with the suffix of cetrans or 5-HT3 antagonist, which is an anti-emetic one. Among that, ondansetron is the drug of choice for chemotherapy or radiotherapy induced vomiting. Among that, ondansetron is a drug of choice for chemotherapy and radiotherapy induced vomiting. Then you have a peristalsis, which is a 5-HT4 blockers, 5-HT4 analogs. So 5-HT4 analogs, all the suffix of pride, cisapride, all those things. So they are all the prokinetic agents, and the cisapride will increase your QT interval. Among that, cisapride will increase your QT interval. So we have talked about the histamines and we have talked about the serotonin. Speaking about the serotonin, 5-HT1, 2, 3, 4 are there. 5-HT1A analog, which is your bisapiron and gepirone, which is used for the treatment of anxiety. 1BRD, treatment of migraine, where you see the triptans. 2A or 2C inhibitor, which is your methyl sergate, ketenserin, and retenserin, present in blood vessels. And 5-HT3 antagonist, which is an anti-emetic, where you have the suffix of cetron. Among that, ondansetron is a drug of choice for chemotherapy or radiotherapy induced vomiting. 5-HT4 agonist, all the prides serves as a prokinetic agent. Among the cisapride can cause a QT prolongation. Among the cisapride can cause a QT prolongation. Okay, these are the important ones you have to know. And apart from that, you have a lipid autocoids. Speaking about the lipid autocoids, you have the membrane phospholipids, where you see the phospholipase A2 will convert the membrane phospholipids to arachidonic acid. And arachidonic acid, by the enzyme, there are two enzymes playing a role in the arachidonic acid. One is your cyclooxygenase or COX. Another one is a lipooxygenase or LOX. Okay, cyclooxygenase or COX. Another one is a lipooxygenase or LOX. So 5-LOX or COX enzyme will play a role here. COX enzyme will lead to the formation of prostaglandin G2 or H2, while 5-LOX leukotriene A4. Leukotriene A4. Apart from that PGG2 or H2, you have a thromboxane A2 synthase, where you see the thromboxane A2 formation, and PGI2 synthase, where it forms a PGI2. Apart from that, isomerase enzyme, which will form PGD2E2 and F2 alpha. D2E2 and F2 alpha. Among that, your aspirin is an irreversible COX inhibitor, which is used as an anti-inflammatory, antipyretic, and analgesic. Apart from that, you have indomethacin, which is used for the closure of your PDA. And what will keep the PDA open, which is your alprastatin. When do you keep the PDA to open? On the transposition of your great vessels. Okay, on the transposition of your great vessels. So apart from the leukotriene, LTA4 will form a LTB4 and LTC4, D4 and E4. Among the B4 is anti-inflammatory, while C4, D4, E4 are the bronchoconstrictors, like a Lucas. So the main function of your prostaglandins or COX inhibitors are your NSAIDs, anti-inflammatory properties. It will be used. Among that, most of them used for the treatment of rheumatoid arthritis people. Among that, most of them are used for the treatment of rheumatoid arthritis. Drugs like aspirin, paracetamol, indomethacin, ibuprofen, diclofenac, nimesulide, piroxicam, and ketorolac, all of them. Among that, paracetamol serves as an antidote for your antidote for your paracetamol poisoning is your N-acetylcysteine, and diclofenac and nimesulide are hepatotoxic, and it is contraindicated in children. And ketorolac is a IV NSAID. Ketorolac is a IV NSAID that you have to remember, people. Apart from that, you have a prostaglandin, apart from that, there are prostaglandin CNS uses. So CVS, it is used as antiplatelets. Prostaglandin I2 causes aggregation of platelet. So there is an improper formation in the clot. So aspirin is an irreversible COX inhibitor, which can serve as your blood thinner. Okay, then you have a GIT, prostaglandin E2 analog, treatment of NSAID induced, it can process a treatment of NSAID induced peptic ulcer disease. You can use a misoprostol or prostaglandin E analog. Apart from that, uterus, PGF2 alpha will cause the contraction of your upper part, and E2 will cause the relaxation of your lower part. Okay, relaxation of your lower part. And apart from that, you have this PGF2 alpha, which is used for the first and second trimester abortion. Okay, first and second trimester abortion, we use as a PGF2 alpha analog. Then you have a I. PGF2 analog will increases the uveosacral outflow, so that is used for the treatment of glaucoma. Increase in the uveosacral outflow is done by your prostaglandin F2 alpha, so it is used for the treatment of glaucoma. Very, 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 very important MCQs, all of them. Systemic effects of your prostaglandins and leukotrienes are pretty important that you have to remember. Okay, among the arachidonic acid is a semi-essential fatty acid. So with this, we have completed your autocoids. With this, we have completed your autocoids. So the next area of interest is your insulin and OHS, people. So endocrine, speaking about the endocrine physiology, in the pharmacology section, we have discussed about everything like the sex hormones and corticosteroids and all the thyroid supplements and everything. But in the case of a review thing, what we are going to talk about is we are going to talk about the anti-diabetic drugs, which is very, 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 very important high yield area. Okay, we're going to talk about this a little bit in an in-depth review. Okay, first one is your insulin. So insulin was discovered by Banting and Best in 1921. And types of insulin: rapid acting, short acting, intermediate acting, and long acting. Okay, rapid acting, short acting, intermediate acting, and long acting. Rapid acting one are your Lispro, Aspart, and Glulisan. Long acting one is your Glargine, Detenavir, and Deglulac, and then Ultralente. While the intermediate is Lente or Isophane, and the short acting is Semilente and regular. Short acting is Semilente and regular. Okay, and remember that Glargine cannot be given at neutral pH, and rapidity of action of regular insulin will be lost when it mixed with the Lente or Ultralente. Okay, when it mixed with the Lente or Ultralente, and mostly we give it through the subcutaneous or IV because that is the one which has a high first pass metabolism, so we cannot able to give him a oral one. Or inhalation, there is a new inhalatory one which is so called as Afrezza inhalatory insulin, but that is contraindicated in asthmatic patient. So important: rapid acting, short acting, intermediate acting, and long acting are the types they may ask you, people. Okay, Lispro belongs to what type of insulin? Glargine belongs to what type of insulin? Isophane insulin is a what type of insulin? And regular insulin is a what type of insulin? All those things will be asked in a FMGE question as a MCQ, people. All those things can be asked as a MCQ that you should not miss. Okay, next is the route of administration. We talked about it, subcutaneous or IV, or maybe the inhalational route you can prefer. And actions: it can decrease the blood glucose, inhibits lipolysis and the synthesis of proteins, and the inhibition of degradation of protein. Okay, inhibition of degradation of protein. So how does it decreases the blood glucose? By stimulating glycolysis, glycogenesis and inhibiting glycogenolysis and gluconeogenesis. Okay, and inhibit glycogenolysis and gluconeogenesis, and it also stimulates a GLUT4, which is an insulin-dependent glucose transporter, where it is located in blood. Skeletal muscle, adipose tissue, and cardiac muscle. Okay, skeletal muscle, adipose tissue, and cardiac muscle. Apart from that mechanism of action, glucose will be entering into the cell through the GLUT2, which is present in the islets of pancreas, and glucose will be converted into glucose 6-phosphate by forming degrading a ATP, and ATP broken down will inhibit the ATP sensitive potassium channel. Potassium will stuck inside the cell, membrane depolarizes as the charge is in the cell, and then you have the calcium opening will be increased. That in turn causes a secretion of insulin, and that in turn causes a insulin secretion. Okay, that in turn causes a insulin secretion, and insulin secretion is stimulated by glucagon, vagus nerve, and beta-2 receptor, while inhibited by somatostatin and alpha-2 agonist. Somatostatin and alpha-2 agonist. Then what are the main indications? Insulin-dependent diabetes mellitus, non-insulin dependent diabetes mellitus, which is poorly controlled in OHS, or in pregnancy, or in DKA or hyperosmolar coma, or infections and surgery, Apart from that, we can also give insulin for the acute hyperkalemia as a binder. Okay, acute hyperkalemia, we can give insulin. Then complications such as hypoglycemia, lipodystrophy at injection site, allergic reactions, sodium and water retention. Sodium and water retention are the complications of your insulin. Okay, so these are the one which is you have to know about the insulin, people. So glucose enters into glucose 6-phosphate, ATP, inhibition of ATP sensitive potassium channel, thereby potassium stuck, membrane depolarizes, calcium channel opening, then insulin secretion. Insulin secretion is stimulated by glucagon, vagus, and beta-2 receptor, inhibited by somatostatin and alpha-2 agonist. Indication: dependent, non-dependent with a poor OHA control, in pregnancy, DKA or hyperosmolar coma, infections and surgery. And third one is acute hyperkalemia. And the third one is your acute hyperkalemia. Then you have a drug interactions. Speaking about the drug interactions, beta blockers, alcohol, drug increasing your blood glucose. Then you have anti-hyperglycemic agents. Speaking about the anti-hyperglycemic agents, we are having an oral and parenteral. Oral one, which releases the insulin and other mechanisms. So we talk about the parenteral first, and then we talk about the oral one. So oral one is your GLP analog, where you see the exenatide and liraglutide, where liraglutide is side effects are weight loss, nausea, and vomiting, and contraindicated in medullary thyroid cancer and men too. Okay, men too. Then you have a amylin analog, which is a pramlinitide, where that suppresses your glucagon secretion, suppresses your appetite, and delays your gastric emptying. So that in turn causes again weight loss and hypoglycemia. Okay. Similarly, one which releases insulin are oral ones which releases the insulin are sulfonylureas and meglitinides, people. So sulfonylureas, what are the drugs which belongs to the sulfonylureas? It could be a first generation and a second generation. Among the second generation is more potent one. Let me put up here. Second generation is more potent one. And first generation one are your chlorpropamide and tolbutamide. Chlorpropamide is the longest acting, and it can cause a dilutional hyponatremia, cholestatic jaundice, and disulfiram-like reaction. While tolbutamide, which is the shortest acting one. Okay, then the second one, glipizide, gliclazide, and glibenclamide. Okay, glipizide, gliclazide, and glibenclamide are the one. Among that, glipizide is safe in elderly patient, and gliclazide has an anti-platelet action also. Okay, among that, gliclazide is having an anti-platelet action also. All of them will suppresses or increases the insulin secretion. All of them which releases the insulin. Now, speaking about the other mechanism of action, that is useful for the treatment of your diabetes mellitus. First one is your biguanide, which is your metformin, which is a universal drug we initiate on the patients with the type 2 diabetes mellitus. So, which is a first line of treatment for type 2 diabetes. It stimulates AMPK and decreases and increase in the it decreases the production and increases in the utilization of your glucose. Decreases the production and increases the utilization of the glucose, and it interferes with the vitamin B12 absorption and also causes a megaloblastic anemia. It interferes with the vitamin B12 absorption and also causes a megaloblastic anemia. Apart from that, what are the things? Diphlobotram latum, we have talked about the vitamin B12 association, and apart from that, metformin, we are talking about it now, and then we will talk about the like a strict vegetarians will develop a vitamin B12 deficiency. Yes or no? So, and it is contraindicated in chronic hypoxic lung failure patient. Metformin is contraindicated in chronic hypoxic lung failure patient and contraindicated in cardiac failure patient. And your metformin is used for the treatment of PCOD also. Now, this is an important MCQ. Nowadays, the question of metformin is due to the PCOD, because one time a student had asked me, like, there was a question which was asked in FMGE, sir, like all of the following statement has been true regarding the metformin except, and they had given like the patient has been prescribed with the the case scenario was given up option, and she said like there is a 21-year-old female with the obese patient, and she presented with the history of PCOD, and the patient has been prescribed with the metformin. So this is one of the answers that you may expect to see. It is also used for the treatment of your PCOD also. It is also used for the treatment of your PCOD also. Then thiazolidinediones. Okay, thiazolidinediones are the another one which has a suffix of glitazone, like a pioglitazone and a troglitazone and rosiglitazone and so on. Among that, the thiazolidinediones are the one where you see the PPAR gamma receptor activators, which are the PPAR gamma receptor activator, which can cause a reversal of insulin and resistance in type 2 diabetes mellitus, which can cause a reversal of insulin and release resistance in type 2 diabetes mellitus. And you have the side effects of troglitazone as a hepatotoxic, and ROSI, which is which can increases your total and LDL cholesterol, and pioglitazone can increases the risk of bladder carcinoma, and overall side effect could be of weight gain, edema, macular edema, and anemia. Weight gain, edema, macular edema, and anemia are the classical side effects of your thiazolidinediones. Okay, then you have alpha glucosidase inhibitors, which is your acarbose, oglibose, and meglitol, which is used for the treatment of both type 1 and type 2 diabetes mellitus. And side effects are meglitol, which is contraindicated in renal failure patient, and D2 agonist, which is a bromocriptine. So it can stimulate the dopamine and alters insulin resistance. And a DPP4 inhibitors, which are gliptins, which are effective orally. And side effects are nasopharyngitis and acute pancreatitis and contraindicated in renal failure patient except linagliptins. Apart from that, vildagliptin, which is contraindicated in hepatic failure, and linagliptin and saxagliptin increases the risk of your heart failure. Then SGLT2 inhibitor, gliflazolin, where side effects increase the incidence of your UTI and increase risk of your fractures. Increases the risk of UTI and increases the risk of fractures are the one where you may see in the case of your, these are the important highlights that you may see in the case of your OHAs. So that is your oral hypoglycemic agents, biguanides, AMPK activation, utilization of glucose. Drug is metformin, used for the treatment of PCOD also, and also patient who needs a weight loss. Thiazolidinediones, glitazones, PPAR gamma. Okay, among that, your troglitazone is a hepatotoxic. Pioglitazone increases the risk of your bladder cancer and it can produce weight gain. Thiazolidinediones can produce weight gain. Then alpha glucosidase, acarbose, oglibose, treatment of type 1 and type 2 diabetes mellitus. Among that, meglitol is contraindicated in renal failure. D2, bromocriptine, increase in bromocriptine alters the insulin resistance. DPP4 inhibitors, gliptins, among that, vildagliptin is contraindicated in hepatic failure, and most of the gliptins are contraindicated in renal failure, except linagliptin. Among that, linagliptin and saxagliptin can increases the risk of heart failure. Last but not least is your SGLT2 inhibitors, which is your gliflozin, dapagliflozin, ramigliflozin, and so on. Among that, it can cause a UTA because glucose will be transported in the urine, and the bugs on the urinary tract love the urine, love the sugar. So obviously they grow on the sugar environment, and they can produce as a UTA. So increased risk of your fractures may also be associated with the gliflozins. Among that, your SGLT2 inhibitors are now the choice of drug, and it is creating a miracles in the diabetes mellitus patients. So that's why SGLT2 inhibitors are the treatment of choice in most of the scenarios. Then you have a respiratory system. So speaking about the respiratory system, so like asthmatic drug are pretty important. Their mechanism of action are pretty important. So first one, antigen will bind with the IgE. Antigen will bind with the IgE, and IgE will interact with the mast cell, and mast cell will undergo degranulation and the release of leukotriene. Leukotriene will bind with the leukotriene receptor, which can produce as a bronchoconstriction. Antigen binds with the IgE to mast cells, and mast cells will degranulate and release the leukotriene, and leukotriene will go and bind with the leukotriene receptor, and then it can produce as a bronchoconstriction. You can contact the admin. The admin will drop you the WhatsApp number. You can get the PDF. Okay. Now speaking about that, so IgE inhibitors are the IgE antigen binding preventers are your omalizumab, and mast cell stabilizers are your sodium chromoglycate, nedocromel, and ketotifen, and so on. And then you have a mast cell degranulation, which releases a leukotriene, where you see the leukotriene synthesis inhibitors such as xylutan and corticosteroids can able to work. And apart from that, LT receptor antagonists like Lucas, Zafer-Lucas, Mantel-Lucas. And apart from that, the last area is your bronchodilation. Bronchodilation will be doing like the drugs which can able to cause a bronchodilation is your SABAs or LABAs, followed by anticholinergic, followed by methylxanthines. Okay, anticholinergics. What are the anticholinergic we saw yesterday? Which was your ipratropium and tiotropium. Yes or no? Which is a bronchodilators in the COPD patients. Yes or no? Apart from that, all the SABAs and LABAs like a salbutamol, formoterol, and so on. Yes or no? So these things can able to produce as a bronchodilation at the end. Then you have a GI pharmacology. Speaking about the GI pharmacology, first one we are going to talk about is the drugs, which is for peptic ulcer disease, where we talked about the gastric acid secretion, all those triple cell theory, everything which was done already on the physiology. But what we are going to study in the pharmacology is what are the drugs, how these drugs are affecting the gastric acid synthesis, and how are we preventing the peptic ulcer disease. Okay, we are going to talk only about this here. So first one is your antacid, where you see the bicarbonates of your sodium, potassium, salt can cause a milk alkali syndrome, which can directly neutralizing your gastric acid production. Antacids can directly neutralizes your gastric acid production. Aluminum salt can produce constipation, while magnesium salt can produce diarrhea. Very, 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 very important MCQ. Okay, aluminum salts can produce a constipation, while magnesium salts can produce a diarrhea. Okay. Then you have a PPIs, all prazoles, for example, rabiprazole, pantoprazole, omeprazole, and so on. All the prazoles, all the drugs which has a suffix of prazoles, which is a drug of choice for peptic ulcer disease of any origin. So anything you see, peptic ulcer disease, or Zollinger-Ellison syndrome, anything which is related to the gastric acid secretion, blindly choose a PPI as a drug of choice. PPA as a drug of choice. As I said yesterday, for the seizures, blindly choose any generalized seizure. Doesn't mean like it have to be a tonic-clonic, or doesn't mean it have to be an absent seizure, or maybe a tonic seizure, clonic seizure, and so on. Blindly choose sodium valproate. Similarly, for any depressive disorders like socialized anxiety, GAD, SAD, PTSD, generalized anxiety, socialized anxiety, post-traumatic stress disorder, bulimia nervosa, anything, choose SSRIs. Similarly, like a POD of any origin, like NSAID induced or Zollinger-Ellison syndrome or normal POD, anything, blindly choose the drug of choice as a PPI. Okay, among that most important PPI is your lansoprazole. Among that most important PPI is your lansoprazole. Then you have the H2 receptor, which is forming your gastric glands. As we said, like your gastric acid secretion is mediated by three things. What are they? Neuronal, hormonal, and paracrinal regulation. Neuronal, vagus nerve. So what will be the neurotransmitter in your parasympathetic nervous system? Cholinergic neuron. Yes or no? Acetylcholine. So we give an anticholinergic to suppress the neuronal regulation. Paracrinal, histamine. We give a H2 receptor antagonist to block the histamine regulation. Okay. So first one is your H2 receptor antagonist, where you see all the tridents. Among that, most potent is your famotidine, and cimetidine on reaction with the dihydrotestosterone can cause impotence and gynecomastia. Can cause impotence and gynecomastia. Apart from that, anticholinergic, which are selective M1 blockers, where you see the pyranzapine and telanzapine. Then you have a prostaglandin analog, PGE2 analog, which is used for the treatment of NSAID-induced peptic ulcer disease, but not a drug of choice. Remember, 10 years back, it was a drug of choice for NSAID-induced peptic ulcer. Now, for any origin of peptic ulcer disease, choose pantoprazole or any prazoles you are seeing. Any prazoles you are seeing. Apart from that, cytoprotectives like a sucralfate and bismuth salicylate. And remember, sucralfate cannot be given with antacid. Remember always, sucralfate cannot be given with antacid. Okay, very, 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 very important MCQ. Why? Because sucralfate cannot work in the alkaline pH. Sucralfate cannot work in the alkaline pH. So when you are giving a sucralfate to that alkaline pH, it work? Because you give an antacid and you raise the stomach pH, and now you are giving a sucralfate. The sucralfate will not work. Okay. Then what is the drug for vomiting? Which is a 5-HT3 receptor antagonist, where you see the cetrons. And drug of choice for all type of vomiting, you can give a cetron, except the delayed cisplatin induced, where the drug of choice is aprepitant. Okay, where the drug of choice is aprepitant. And anticholinergic like a scopolamine and a hyoscine can able to treat for the motion sickness. Apart from the D2 antagonist, we can give the very, very important one is your levodopa induced vomiting. The drug of choice is domperidone. Very, 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 very classic MCQ. What is the drug of choice for levodopa induced vomiting? Which is your domperidone. Then you have a GI motility 5-HT4 agonist, which is a prokinetics. Among that, all trites will come under this category. And drugs for inflammatory bowel disease. So the main treatment is 5-amino salicylic acid. Apart from that, glucocorticoid, drug of choice for ulcerative colitis and Crohn's. You can give a glucocorticoid. And methotrexate, you can use it to treat in Crohn's, but not in ulcerative colitis. Very, 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 very important. This was the question of negation, which was asked several times in FMGE. Like methotrexate can be used to treat your ulcerative colitis, not as a pharmacology question, but as a medicine question. It has been asked several times. Methotrexate is a drug which is used to treat the ulcerative colitis. No, that was always all of the following statement regarding the ulcerative colitis are true, except which was given. Okay, as a question of negation, you may always see this methotrexate, which is used for treatment in your Crohn's, but not in the ulcerative colitis. While glucocorticoid, we can use it for both. Okay, for both Crohn's and ulcerative colitis. From moderate to severe cases, we can use this glucocorticoid for the treatment. But for the methotrexate treatment is only for the Crohn's, not for the ulcerative colitis. You have to remember that. So speaking, shall we revise the GIT and respiratory? bronchodilators or like ipratropium, tiotropium, and then you have a sabas, and then you have a labas, methylxanthine, or the one which are bronchodilators. LT agonists are Lucas. LT synthesis inhibitors are corticosteroids and xylutine. Master cell stabilizers are sodium chromoglycate, netochromyl, and ketotifen, while IgE are omalizumab 1. Okay. Apart from the GI, so what are the drugs in the GI? Peptic ulcer disease, antacid, among the magnesium salt produce diarrhea, aluminum produce constipation. PPI, all prazoles, most potent is lansoprazole. H2 receptor antagonist, all tidine, most potent is famotidine, and cimetidine can cause gynecomastia. Okay, then you have the H2 anticholinergic, pyranzapine and telanzapine. Prostaglandin analog, E2 analog, misoprostol, is used for NSAID-induced peptic ulcers. Cytoprotectives are sucralfate and bismuth substrate. Among the sucralfate cannot be given with the antacid. And for vomiting, all the vomiting you have to give up 5-HT3 blockers, except like chemotherapy-induced vomiting, delayed one, where the drug of choice is apripitan. And then for anticholinergic, for motion sickness, and then you have this levodopa-induced vomiting, drug of choice is domperidone. And drugs for GI motility, prokinetic, all the cisapride can cause a QT prolongation. And metoclopramide, IBD, main treatment is salicylic acid derivatives, glucocorticoids, and you can also use a methotrexate for the Crohn's. Okay, clear about that? So we have done the ANS, we have done the CNS, we have done the CVS, we have done the respiratory, we have done the GIT, we have done the autocoids, we have done the endocrine. So the last portion of your pharmacology, the very last portion of your pharmacology is your antimicrobial, where I concised into 7 to 8 pages. So remember this 7 to 8 pages so that you can able to understand most of the things. And once you can able to understand, this is kind of like a high yield one where you can able to get good questions in this antimicrobial. So this is kind of like, piece of cake for you. This is kind of like a piece of cake for you. And you can able to take it, like a mug up and write down so that you can able to answer most of the question in the antimicrobial. So first one is your bacterial cell wall synthesis inhibitor. So antimicrobials, we talk about first one, cell wall synthesis. And in the cell wall synthesis, then we talk about the inhibitors. Okay, bacterial cell wall synthesis, UDP derivatives of NAM, NAG will be used. So first we take a UDP NAG, will be condensed with the phosphoenol pyruvate and reduction and forms a UDP NAM. UDP NAM. And UDP NAM will undergo amino acid attachment with the degradation of ATP and forms UDP NAM pentapeptide unit. And forms what? UDP NAM pentapeptide unit will be formed over here. Okay, fine. UDP NAM pentapeptide has been formed. Now, on the cellular surface, this UDP NAM pentapeptide unit will combine with bactoprenol phosphate. It will combine with bactoprenol phosphate and eliminates the UMP so that you may get bactoprenol phosphate, and here you may get a 1 phosphate, and here you may get a 1 phosphate, NAM pentapeptide. All of them will combine together to form a bactoprenol double phosphate NAM pentapeptide unit. Bactoprenol double phosphate NAM pentapeptide unit. And in that bactoprenol double phosphate NAM pentapeptide unit, you may have the addition of your UDP NAG. You may have the addition of your UDP NAG, and then there is a UDP will be eliminated. So NAG will be attached over here. Only NAG will be attached over here so that you may get bactoprenol double phosphate NAM NAG pentapeptide unit. Bactoprenol double phosphate NAM NAG pentapeptide unit, and this bactoprenol double phosphate NAM NAG pentapeptide unit will cross the cell membrane, and inside the cell membrane this NAM NAG pentapeptide unit will be attached with the peptidoglycan layer. And forms peptidoglycan NAM NAG pentapeptide unit, and forms a peptidoglycan NAM NAG pentapeptide unit. And this conversion of this attachment of your NAM NAG pentapeptide to the previously synthesized peptidoglycan is inhibited by vancomycin. So then you have a bactoprenyl double phosphate. This bactoprenyl double phosphate will be going into the surface by eliminating the phosphate. This migration is inhibited by bacitracin. This migration is inhibited by bacitracin. Okay, fine. We talked about the synthesis. Now the peptidoglycan NAM NAG pentapeptide will undergo cross-linking and forms the cell wall. Cross-linking is mediated by penicillin binding protein, which can stimulate the transpeptidase enzyme that in turn mediates the cross-linking. So we have that beta-lactamase inhibitors. This beta-lactamase inhibitor will cause the inhibition of beta-lactamase enzyme. This inhibition of beta-lactamase in turn causes a failure in the synthesis of penicillin binding protein. Failure in the synthesis of penicillin binding protein could not activate the transpeptidase enzyme. Transpeptidase enzyme is inactivated, cross-linking is impaired, cell wall synthesis will be impaired. So what are those beta-lactamase inhibitors, people? Penicillin, cephalosporin, monobactam, and carbapenem. Penicillin, cephalosporin, monobactam, and carbapenem. So this is all about the bacterial cell wall synthesis. UDP NAG condensed with the phosphoenol pyruvate to form a UDP NAM. With the attachment of amino acid, they form a UDP NAM pentapeptide unit along with the bactoprenyl phosphate. Then it may convert into bactoprenyl double phosphate NAM pentapeptide. Then it attaches with the UDP NAG to form a bactoprenyl double phosphate NAM NAG pentapeptide. Then they migrate where the NAM NAG pentapeptide will be attached with the peptidoglycan layer, and then your bactoprenyl double phosphate will goes to the surface by eliminating a phosphate. Elimination is inhibited by bacitracin. Peptidoglycan attachment is inhibited by vancomycin, and amino acid attachment is inhibited by cycloserine. And then peptidoglycan cross-linking is inhibited by beta-lactamase inhibitor such as penicillin, cephalosporin, monobactam, and carbapenem. Monobactam and carbapenem. If we study about all these 4 classes, we can able to complete the cell wall synthesis, people. We can able to complete the cell wall synthesis. So shall we study about this all 4 things? Shall we study about this all 4 things? First one is your penicillin. Among that penicillin, the main drug we are going to talk about is your penicillin G. Penicillin is penicillin G, which is the shortest acting. In order to enhance the T half, we can add either a benzathine or procaine, and to convert the penicillin G into benzathine penicillin or procaine penicillin. Penicillin is a drug of choice for last mast. Remember with the mnemonic of last mast. Remember with the mnemonic of last mast, where you may see where L stands for leptospirosis, actinomyces, and staphylococcus, treponema, meningococcus, anthrax, streptococcus, and tetanus. Okay, last mass. Leptospiro, actinomyces, staphylococcus, treponema, meningococcus, anthrax, streptococcus, and tetanus. Streptococcus and tetanus. Then you have a penicillin, which is acid resistant and extended spectrum, and penicillin is resistant. So acid resistant penicillin are, remember with the mnemonic of cloxacillin attacks visceral digestive organs. Cloxacillin attacks visceral digestive organ. Acid resistant penicillin are cloxacillin, amoxicillin or ampicillin, penicillin B, digoxacillin, and oxacillin. Digoxacillin and oxacillin are the one where you have to see acid resistant penicillin. Cloxacillin, amoxicillin or ampicillin, penicillin B, dicloxacillin, and then you have a oxacillin, and then you have the oxacillin. Then for an extended spectrum, you have a amino group, carboxy group, and urido group. Amino groups are your amoxicillin and ampicillin, amox and amphi. Drug of choice for listeria meningitis, and side effects are maculopapular rash and pseudomembranous colitis. Maculopapular rash and pseudomembranous colitis. Carboxy, carbenicillin, and ticoxylin. Urido group, I used to remember with the mnemonic of MAP. Meslazillin, aslazillin, and piperazillin. Piperazillin is for Pseudomonas. Piperazillin is for Pseudomonas. Apart from that, penicillin resistant, I used to remember with the mnemonic of NOCMD, napsillin, oxacillin, cloxacillin, methicillin, and dicloxacillin. Among that, napsillin causes neutropenia, oxacillin is can cause a hepatitis, and methicillin causes interstitial nephritis. Methicillin causes interstitial nephritis. Okay, naphthalene causes neutropenia, oxacillin hepatitis, methicillin interstitial nephritis. Methicillin interstitial nephritis. Okay, then this is all about your, penicillins. This is all about your penicillins. Then you have a cephalosporin. There are lot of drugs in the cephalosporin, people. Remember, Ceph with the A is first generation. Ceph with the PA on the word, fourth generation. ROL, fifth generation. And the suffix of ME or O, 1 or 10, then that is the third generation, except cefuroxime. Okay, all of them, the third generation cephalosporins are all against the gram negative, which can cross blood-brain barrier. Exceptions are cephalosporin and cefoxam. Among that, ceftazidime and ceftriaxone. Ceftazidime is for melioidosis, where you see the B pseudomalloid, and ceftazidime plus aminoglycoside is for pseudomonas. And ceftriaxone is a drug of choice for, gonorrhea, salmonella, E. coli, proteus, serratia, haemophilus, and klebsiella. It can cause a biliary sludging syndrome and gallstone. That is your cholelithiasis. It can cause a biliary sludging syndrome and cholelithiasis. Okay, and toxicity, it can cross reacts with the penicillin. And these drugs with the methylthiotetrazole can cause hyperprothrombemia and disulfiram-like reaction. What are these drugs with the methylthiotetrazole group, which are your cefamandole, cefoperazone, and moxolactam, and cefotaxime. Okay, cefotitam, and you have this moxolactam, cefoperazone, and cefamandole are the one which has a methylthiotetrazole group. Okay, Cef-A is first generation, Cef-Pi is fourth generation, ROL is fifth generation, where you see the commonly acquired pneumonia, and the suffix of Me are 1 or 10, which is a third generation, except cefotaxime against your gram negative and crosses your, BBB. Exceptions is, exceptions is your cefoperazone and cefixime. Among that, ceftazidime is a drug of choice for melioidosis, and ceftazidime plus aminoglycoside treatment of pseudomonas. Ceftriaxone is a drug of choice for gonorrhea, salmonellosis, E. coli, proteus, serratia, haemophilus, and klebsiella. Can cause a biliary sludging syndrome and cholelithiasis. Then you have this third category. Which is a monobactam. The only drug is your aspirant, where you have the penicillin or cephalosporin, resistance. You can give this aspirant. Then you have the carbapenem. Drug of choice. I used to remember with the mnemonic of ESA enter castle. ESA enters the kingdom, where E stands for Enterobacter, S stands for Serratia, A stands for Acinetobacter, and E stands for ESBL, and kingdom K stands for Klebsiella. While the drugs which belong to the carbapenem category are imipenem, doripenem, meropenem, and ertapenem. Are the drugs which belongs to this carbapenem category. What are they? Imipenem, doripenem, meropenem, and ertapenem. Among that, imipenem is a drug which works synergistically with the cilastatin, people. Imipenem is the drug which works synergistically with cilastatin and causes the inhibition of your renal dehydropeptidase 1 enzyme, which can causes the inhibition of renal dehydropeptidase 1 enzyme. And side effects include GI distress and seizures. Okay, the side effects include GI distress and seizures. Then you have the vancomycin, peptidoglycan formation inhibitor, drug of choice for MRSA and Corynebacterium GKM. While the side effects of vancomycin are pretty high yield one, where the side effects are Redman syndrome and thrombophlebitis, ototoxicity, and nephrotoxicity. Remember, we had given both your Redman syndrome and thrombophlebitis were asked in FMGE previously. So remember, the important side effects are Redman syndrome and thrombophlebitis for vancomycin. Drug of choice for MRSA and Corynebacterium GKM. This was also asked in FMGE, where you should not forget. Then you have a phosphomycin, enol pyruvate transferase inhibitor, mostly drug of choice for uncomplicated UTA. You can give drug of choice for uncomplicated UTA. You can give this uncomplicated UTA. You can give a phosphomycin. So this is all about the cell wall synthesis inhibitor, people. This is all about the cell wall synthesis inhibitor. So we have talked about the 4 classes of drugs. We have talked about the 4 classes of drugs: penicillin, cephalosporin, and monobactam and carbapenem. So speaking about the penicillin, we talked about the important one, drug of choice for last mass. Drug of choice for last mass: Leptospira, Actinomyces, Staphylococcus, Treponema, Meningococcus, Anthrax, Streptococcus, and Tetanus. Anthrax, Streptococcus, and tetanus. Apart from that, Listeria, the drug of choices, ampicillin, and like you have the piperacillin is used for the treatment of Pseudomonas. Nafcillin causes neutropenia. Oxacillin causes hepatitis. And cephalosporins, speaking about the cephalosporins, ceftriaxone and ceftazidime are the 2 drugs, important one. We have talked about that. Ceftriaxone is a drug of choice for gonorrhea, salmonella, E. coli, proteus, serratia, Haemophilus, and Klebsiella. While side effects are biliary sludging syndrome and cholelithiasis. While ceftazidime is a drug of choice for your melioidosis. Drug of choice for melioidosis, you have using a like a ceftazidime as a drug of choice. Okay, apart from that, you have a monobactam. The drug aspirant is there for the penicillin and the cephalosporin, like a resistance. And carbapenem, ESL enter kingdom, Enterobacter, Serratia, Acinetobacter, ESBL, and Klebsiella was the mnemonic. And drugs such as drugs come under the category of carbapenem are imipenem, doripenem, meropenem, and like ertapenem. Among that, imipenem works synergistically with the cilastatin to form the inhibition of your renal dehydropeptidase 1. And vancomycin inhibits peptidoglycan formation, drug of choice for MRSA and Corynebacterium GKM. Side effects include Redman syndrome, thrombophlebitis, ototoxicity, and nephrotoxicity. Ototoxicity and nephrotoxicity. Then you have a phosphomycin, which is used as a drug of choice for uncomplicated UTI. Mechanism of action is inhibition of enol pyruvate transferase. Inhibition of enol pyruvate transferase. Now we move on to the next area, the drugs which can act on the protein synthesis. Whatever we have talked about till now was the drugs which act on the cell wall synthesis. Now protein synthesis, I used to remember with the mnemonic of bi at 30 and cells at 50. Bi at 30 and cells at 50. So 30 as ribosome, aminoglycosides, and tetracycline, while 50 as chloramphenicol, clindamycin, erythromycin, lincomycin, linezolid, and streptogramins. Linezolid and streptogramins. So first we talk about the tetracycline. All of them are teratogenic and excreted in urine except doxycycline, which is excreted in the feces. While we are classifying the tetracycline on the group 1, 2, and 3. Group 1 is tetracycline, chlor, and oxytetra, while group 2 is demiclocycline and limecycline. Demiclo and lime. Demiclo is used for the treatment of SIADH, which can precipitate diabetes insipidus, and doxy and minocycline. Minocycline is used for the treatment of leprosy. Minocycline is used for the treatment of leprosy. Okay, among that, side effect can result in the Fanconi syndrome, and you have the hepatic nephrosis, and apart from the teratogenic. So very, 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 very important is this MCQ. Consumption of expired tetracycline could result in Fanconi syndrome. Consumption of expired tetracycline could result in Fanconi syndrome. And side effects are teratogenic and hepatic necrosis. Side effects are teratogenic and hepatic necrosis. While the uses, treatment of lymphogranuloma venereum, granuloma inguinale, cholera, brucellosis, relapsing fever, Lyme's disease, rickettsial infection, and chlamydial infection. Rickettsial and chlamydial infection. All of them, the drug of choice is doxy. All of them, the drug of choice is doxy. Okay. Next, you have aminoglycosides. So speaking about the tetracycline, what are the things you have to remember is tetracycline, like a main important one is your minocycline for the treatment of leprosy, and demiclocycline is for the treatment of SIADH. Consumption of expired tetracycline causes Fanconi syndrome, and doxy is used for the treatment of Lyme's disease, rickettsial, chlamydial, relapsing fever, and it can also used as a malaria prophylaxis, and it can also used as a malaria prophylaxis. Then you have aminoglycosides. Aminoglycosides, all the mycin, streptomycin, gentamicin, kanamycin, topramycin, amikacin, and all the mycin. Among that, streptomycin is a drug of choice for Burkholderia mallae and Yersinia pestis. Okay, Burkholderia mallae and Yersinia pestis, along with the tetracycline, the streptomycin is also used. Streptomycin is also used. And macrolides, which can prevent the cystic fibrosis exacerbation. So drugs like azithromycin, erythromycin, roxithromycin, and clarithromycin belongs to the macrolide category. Among that, azithromycin is used for the treatment of prophylaxis of Mycobacterium avium and chlamydia, MAC, toxoplasmosis, H. pylori, and H. pylori, while macrolide serves as a drug of choice for CLAW. Remember, with the mnemonic of CLAW. So C stands for 3C, which is your Campylobacter, chancroid, and Corynebacterium diphtheriae. Campylobacter, chancroid, and Corynebacterium diphtheriae, while L stands for Legionella, A stands for atypical pneumonia, and W stands for whooping cough. W stands for whooping cough. So macrolides, drug of choice for CLAW, we are having a 3Cs. What are they? Campylobacter, chancroid, and Corynebacterium diphtheriae. And then you have a L for Legionella, A for atypical pneumonia, and W for whooping cough. And W for whooping cough. Then you have a side effects. Side effects were diarrhea, cholecystatic hepatitis, and infantile hypertrophic pyloric stenosis. Infantile hypertrophic pyloric stenosis. And then you have a spiromycin, which is a drug of choice for toxoplasmosis in pregnancy. And clindamycin is a drug of choice for gas infection, treatment of pneumocystitis jirovecii and Toxoplasma gondii, and the treatment of pseudomembranous colitis. And side effect for clindamycin is hepatic dysfunction. Hepatic dysfunction. So drug of choice for group A streptococcus is clindamycin. Corynebacterium diphtheriae is macrolides. Then you have a linezolid, which is a drug of choice for ERSA. Side effect could cause a serotonin syndrome and thrombocytopenia and neutropenia. Thrombocytopenia and neutropenia. Then you have a chloramphenicol, which is an inhibition of peptidyl transferase, where you see the bone marrow suppression and gray baby syndrome. Another important MCQ. Red man syndrome, vancomycin. Gray baby syndrome, it is a chloramphenicol. Then you have a streptogramins, which can produce arthralgia and myalgia symptoms. Okay, which can produce arthralgia and myalgia symptoms. Then you have anti-metabolites, which is your sulfonamides. Mechanism of action is inhibition of folate synthase. Sulfonamide for systemic use, short-acting, medium-acting, and long-acting. Sulfazoxazole, sulfamethiazide, and then sulfacysteine. Okay. Then medium-acting ones are sulfamethoxazole and sulfadiazine, while long-acting ones are sulfadoxine. Okay, long-acting ones are sulfadoxine. While for GIT, sulfasalazine and oslazalazine, and for topical, sulfacetamide, mafenide, and then you have the silver sulfadiazine. Among that, silver sulfadiazine is used for the treatment of fungal keratomycosis people. Fungal keratomycosis. Among that, sulfadiazine, along with the pyrimethamine, is used for the treatment of malaria and toxoplasmosis. Okay, what are the side effects? I used to remember with the side effects of ABC rash. As ABC rash, where A stands for aplastic anemia, bilirubin displacement, crystalluria, R stands for rash, acetylation, SLE, and hemolysis. SLE and hemolysis. That is a ABC rash. Then you have a trimethoprim, inhibition of dihydrofolate reductase. Inhibition of dihydrofolate reductase. Side effect of megaloblastic anemia, neutropenia, pancytopenia, and hyperkalemia. And cartrimoxazole, trimethoprim, and sulfamethoxazole combo is so called as cartrimoxazole, while the ratio is important, 1:5. And it is also a drug of choice for three things, people. I used to remember with the mnemonic of BNP. Okay, not the brain natriuretic peptide one, but BNP is a drug of choice. Sorry, cartrimoxazole is a drug of choice for BNP conditions. What are they? B stands for Burkholderia cepaci. B stands for Burkholderia cepaci, and N stands for nocardiosis, and P stands for pneumocystitis, and P stands for pneumocystitis. So cartrimoxazole ratio 1:5, drug of choice for BNP, Burkholderia cepaciae, nocardiosis, pneumocystitis. Okay, then you have a quinolones, which is contraindicated in pregnancy, and along with the NSAIDs, it can able to increase the toxicity. Okay, and you know that the quinolones is a mechanism of action is inhibition of your DNA gyrase. DNA gyrase. Among that, the important quinolones you have to know is ciprofloxacin, which is a drug of choice for Bacillus anthracis and the prophylaxis of meningococcal meningitis. Okay, meningococcal meningitis. Then levofloxacin, maximum oral bioavailability, and sparfloxacin can be able to prolong the QT interval. Can able to prolong the QT interval. Okay, then you have an antifungal. Then you have the antifungal drugs. So far we have done with the antimicrobial drugs. So far we have done with the antimicrobial drugs. Now we are moving on to the antifungal drug. Now we are moving on to the antifungal drug. Speaking about the antifungal, we are having a 4 mechanism of action, people. We are having a 4 types of mechanism of actions for the antifungal. One is your drugs which alters your membrane permeability. One is your drugs which alters your membrane permeability, and the drugs which blocks your nucleic acid synthesis. Drugs which blocks your nucleic acid synthesis, and the drugs which disturbing your microtubule function, which can disturbing your microtubule function, and drugs which inhibits your cell wall synthesis. Drugs which inhibits your cell wall synthesis. So what are the drugs which alters your membrane permeability? Are your azoles, which is your imidazole and triazole. Imidazole is a ketoconazole, which can cause gynecomastia. And triazole, on the triazole, we are having a fluconazole and itraconazole. Speaking about the fluconazole, drug of choice for candidiasis and coccidiodal, and then cryptococcal. While itraconazole, we are having a blastomycosis. We are having a blastomycosis and paracoccidioidomycosis, histoplasmosis, and you have this coccidioidomycosis and spirotrichosis, and then you have this mycetema, and then you have this prophylaxis of neutropenia. All of them, the drug of choice is itraconazole. All of them, the drug of choice is itraconazole. So blastomycosis, paracoccidioidomycosis, histoplasmosis, coccidioidomycosis, pyrotrichosis, mycetema, and prophylaxis of neutropenia. Among that, we used to remember it as a mnemonic of BPH contract, senior male patients. BPH contract, senior male patient is the mnemonic of drug of choice for itraconazole. Drug of choice for itraconazole. Then you have a polyenes, where you see the amphotericin B. Mechanism of action is binds with the ergosterol and causes the formation of artificial pore. So technically, like what we used to say is amphotericin B can puncture anywhere. Okay. So for a fungal cell membrane, it can puncture your fungal cell membrane. And it is also used as a wide spectrum, like an antifungal agent. Wide spectrum antifungal agent. And it is considered to be most of the fungal infection we can use as this amphotericin B. And it can able to, like creates artificial pores. As we say, in a common language, what we say, the amphotericin B can puncture anything. So similarly, we can able to, it is causing a nephrotoxicity. Amphotericin B induced nephrotoxicity, especially on the post-COVID patient with the mucor. We are seeing a lot of cases, people. Okay, amphotericin, because we used to say like, whenever you are giving a amphotericin B, you should involve the nephrologist there. Okay, whenever you're prescribing an amphotericin B, you have to involve like a nephrologist there to monitor your serum urea and creatinine. Because nowadays in the post-COVID, like a mucormycosis, we are expecting a lot of cases with the mucormycosis, and the drug of choice is amphotericin B. And whenever you see whenever you give the amphotericin B, there is a higher chances that it may progress into the nephrotoxicity. There is a higher chances that it may progress into the nephrotoxicity. So you have to be very, very careful about that. Then apart from that, hypokalemia, hypomagnesemia, anemia, and seizures can able to be associated with the amphotericin B toxicity. So far, what I have seen from my experience with the amphotericin B toxicity was amphotericin B induced nephrotoxicity a lot of patients. A lot of patients with the amphotericin B induced nephrotoxicity. And like there are almost like a 10 to 12 patients with the amphotericin B induced seizures. Very, 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 very rare, but I had seen almost like a 5 to 10 people while during the amphotericin B infusion they develop a seizure. Okay, apart from that remaining things, those are all like electrolyte dysfunction. So we cannot able to identify whether the patient causes causing this electrolyte dysfunction or maybe due to the amphotericin B toxicity. The prominent marker is nephrotoxicity. Okay, you have to be understanding this. And then you have the drugs which blocks the nucleic acid synthesis, which is your flucytosine, where you see the cytosine deaminase to 5-fluorouracil, and the side effects are bone marrow suppression, alopecia, and liver dysfunction. Bone marrow suppression, alopecia, and liver dysfunction. And drugs disturbing the microtubule formation is your griseofulvin, which can cause a disulfiram-like reaction. And drugs which inhibits the cell wall synthesis is caspofungin, which is used for the drug of choices, Candida glabrata and Candida cruzi. Apart from that, isoconazole is an orphan drug. Very, 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 very important MCQ. Isoconazole is an orphan drug. Orphan drug means what? Used for the treatment of rare diseases. Used for the treatment of rare diseases, we use the orphan drugs. Okay, rare diseases, we use the orphan drug. Among that, isoconazole is a orphan drug. Isoconazole is a orphan drug. Then you have voriconazole, which is a drug of choice for invasive aspergillosis and fusarium and pseudosporium. Fusarium and pseudosporium, you are having a voriconazole. Voriconazole. This is all about the antifungal, people. So this is all about the antifungal. 4 mechanism of action. Drug which alters your membrane permeability, azoles. Speaking about the azoles, ketoconazole, side effect is gynecomastia, triazole, fluconazole, and itraconazole. Fluconazole causes candidiasis, coccidioides, and cryptococcal, while itraconazole, BPH contract, senior male patient was the mnemonic. Okay, so blastomycosis, paracoccidioidomycosis, histoplasmosis, coccidioidomycosis, pyrotrichosis, mycetema, both mycetema as well as actinomycetema, and then prophylaxis of neutropenia. And then you are having a prophylaxis of neutropenia. And then drugs which blocks the nucleic acid synthesis, flucytosine, where the cytosine deaminase to 5-fluorouracil conversion is inhibited. And apart from that, you have the amphotericin B. Like it forms an artificial pore in the fungal cell membrane. Wide spectrum antifungal can cause nephrotoxicity, hypokalemia and magnesemia, anemia, and seizure. And griseofulvin, disulfiram-like reactions, caspofungin, drug of choice for Candida glabrata and Candida cruzi, isoconazole, orphan drug, voriconazole, invasive aspergillosis, fusarium, and pseudosporium is a drug of choice. Okay, for invasive aspergillosis, fusarium, pseudosporium, voriconazole is a drug of choice. Okay, voriconazole is a drug of choice. So far, we have done the antifungal. This table is also one of the 3-star rated table, people, which is you can draw it in the table and you can just mug it up, which is quite very, 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 very important one. And you can score a very good score out of it. Okay, and you can score a very good one out of it. Next is your anti-helminthic. So inhibition of your beta tubulin, mebendazole and albendazole. Albendazole is a drug of choice for, as a review point of view, you have to remember albendazole is a drug of choice for all nematode and cystode except entropium, where the drug of choice is mebendazole, and Ucheria and Brugia, drug of choice is DEC, diethyl carbamazine, and then onchocercosis and strongyloides, ivermectin, dracunculus, metronidazole. Dracunculus, metronidazole. Okay, albendazole is a drug of choice for all nematodes and all nematodes and neurocysticercosis except entropium, Ucheria, Brugia, Onchocerca, Strongyloides, Dracunculus. Entropium, drug of choice is mebendazole, Ucheria, DEC, Brugia, DEC, Onchocerca, ivermectin, Strongyloides, ivermectin, Dracunculus, metronidazole. Dracunculus, metronidazole. And for all the cestodes, you use a praziquantel. Praziquantel is a drug of choice for all cestodes and trematode. Exception is fasciola hepatica and hydatid cyst. Fasciola hepatica and hydatid cyst, where the drug of choices for fasciola hepatica triclobendazole, and for hydatid cyst it is a albendazole. For hydatid cyst it is a albendazole. So all nematodes and neurocysticercosis, drug of choice is albendazole, exception 4 categories. Okay, entropium, mebendazole, Ucheria and Brugia, we give a DEC, Onchocerca and strongyloides, we give a ivermectin, dracunculus, metronidazole. All cestodes and trematodes, praziquantel is a drug of choice except fasciola hepatica, where you see the triclobendazole as a drug of choice, and hydatid cyst, where you see the albendazole as a drug of choice. You have to remember this, people. Okay. Then you have an antimycobacterium. You have the first line of drugs, HRZES. HRZES is the first line of drugs. So speaking about the HRZES, isoniazid, inhibition of mycolic acid synthesis, it is both bacteriostatic and bactericidal. Drug of choice for prophylaxis of TB and resistance, can cause a mutation in CAT gene and CAT G and inhibin A, and a side effect peripheral neuritis, which is treated by pyridoxine, and gynecomastia, psychosis, rash, fever, and anemia, and then it can cause a transient memory loss. It can cause a transient memory loss. Okay. So, and also you have to monitor your ALT and AST levels because it is a hepatotoxic one. It can cause a hepatotoxic one. Apart from that, you have this rifampicin. Speaking about this rifampicin, it is a bactericidal, inhibition of DNA-dependent RNA polymerase, and prophylaxis of meningococcal and staphylococcal carrier state. Prophylaxis of meningococcal and staphylococcal carrier state, and best for bacteria in caseous necrosis. Where rifampicin, the classical thing you may see is a orange color urine and orange staining. Okay, orange color urine and orange staining. Most of the time, the nurses used to be the new nurses who like freshers, they come to you in the ICU that the patient is passing a hematuria. The next question you have to ask is the patient on ATT? Is the patient on ATT? Then if the patient is on anti-tubercular drug, then it is the hematuria is not an actual hematuria. It is due to the orange color urine, which is caused by the rifampicin, which is a component of your ATT. Okay, you have to remember that. And then hepatotoxicity, it is also, so you have to monitor his LFTs. Drug interaction with the rifabutin, which is not required nowadays. Apart from that, pyrazinamide can cause hyperuricemia and retrobulbar neuritis. Ethambutol, which is a bacteriostatic, can cause optic neuritis. Contraindicated in children. Streptomycin, contraindicated in pregnancy. You have to give through the IM injection, and it has a minimal CSF penetration. Then you have a thioacetazone, contraindicated in AIDS patient. Kanamycin, MDR resistant TB. Capromycin, side effects are ototoxicity, nephrotoxicity, hypokalemia, hypomagnesemia. Fluoroquinolones, Mycobacterium avium. Ethionamide, hypothyroidism. Bedaquiline, we are having a side effects of QT prolongation. I had seen one case of bedaquiline induced QT prolongation in a patient who came to me for the another reason. Okay, so that we are finding the QT prolongation reason and what are the drugs that can able to produce a QT prolongation. At that time, we had found that it was a bedaquiline which can able to cause a QT prolongation. You have to remember that. You have to remember that. So we covered most of the drugs, people. We covered most of the drugs. So with this, we are finishing the pharmacology. So we take a small break and see you by 4:25. 4:25. See you around the like a 4:25. So we can proceed with the PSM. And the PSM is a very vast portion, so we try to cover it within today and tomorrow. Okay, so take a break of 10 minutes and come back by 4:25. Take a break of 10 minutes and come back by 4:25. Okay. So we are resuming the session. Speaking about the resuming the session, we are going to talk about the PSM now. So we have done with all the basics except the forensic medicine. On the clinical subjects, we have done our anesthesia and dermatology. Okay. Now today we are going to talk about your PSM. With that, we are completing the entire, like your basic series. And after your basic series, you are about to complete, like 42% of your FMGE portion. Then remaining 56, we will do that in the upcoming days. So speaking about the PSM, there are certain highlights are important in the PSM, and PSM is kind of like like a ruler of your morning paper. We used to say, how do we say it? Like for example, like if you're counting your indirect questions from your nutrition and indirect questions from your microbiology, if you count it, if you're reading it, if your communicable and non-communicable diseases are good, and you have excellent understanding of your subjects like like a pediatrics or things, then you may expect these type of questions in PSM too. So if you study your PSM very good, almost like a 1 out of 3 questions, it may sounds like PSM question, but it was technically not a PSM, but from the other subjects too. But like your way of understanding will pick you out to direct you to the subject of PSM. So understanding the PSM is very, 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 very important. There are a lot of concepts and lot of things you have to remember for the PSM. That's why we made it for the 2 sessions only for PSM. Maybe you may have a 2 upcoming sessions with the 4 of us or 4.5 hours. We can complete it in a very nice way. The PSM. We will proceed with the PSM people now. Speaking about the PSM, the first area we are talking is going to be your history of medicine. Quite a low yield area, but there are certain highlights you have to know. That's why I had given a like a paper which talks about the history of medicine. Okay, so low yield area, but there are still the concepts you have to know. Okay, so one is your father of homeopathy. Who is the father of homeopathy? Samuel Hahnemann. Samuel Hahnemann is the father of homeopathy. And what are the principles of homeopathy? Similia similibus curantare, and a single medicine at the time of treatment and minimum dose to be used. Similia similibus curantare, single medicine at the time of treatment, minimum dose to be used. Minimum dose to be used. Then you have Ayurveda. Ayurveda is so called the science of medicine, and Ayurveda follows the Tridosha theory. What is that? Vata, Pitta, and Kapha. Vata, Pitta, and Kapha is so called the Tridosha theory, and Ayurveda follows this Tridosha theory. And then you have the Unani. Unani follows the four principles. The 4 principles of Unani are blood, phlegm, yellow bile, and black bile. Blood, phlegm, yellow bile, and black bile are the 4 principles or 4 components of your Unani system of medicine. So very, very important. Next important highlights is the important theories and their inventors. Germ theory, Louis Pasteur. Multifactorial causation of disease, Patent Coffer. Spontaneous generation theory, Aristotle. The term vaccination was coined by Edward Jenner. Term vaccine was coined by Louis Pasteur. And the growth chart was invented by David Marley. Growth chart, David Marley. Vaccine was coined by Louis Pasteur. Vaccination was coined by Edward Jenner. Spontaneous generation theory was coined by Aristotle. Germ theory, Louis Pasteur. Multifactorial causation of disease, it is a Patent Coffer. It is a Patent Coffer. And who are the important fathers? The father of medicine is Hippocrates. Father of Indian medicine, Charaka. Surgery is Ambrose Bohr. Indian surgery is Sushruta. Epidemiology is John Snow. While father of public health is cholera. Remember that father of public health is not the person, it is the disease. So we used to call that as a cholera is a father of public health. Then types of medicine, we are having a state medicine and a socialized medicine and social medicine. State medicine, socialized medicine, and social medicine. Speaking about the state medicine, free medical services to the people. at a government expense. Free medical services to the people at government expense is so-called as state medicine, and the provision of medical service and professional education by the state is socialized medicine. But the problem here is this: the program is operated and regulated by professional group, not by the government. Okay, what is a state medicine? Medical services to the people at government expenses, state medicine. What is a socialized medicine, people? Socialized medicine means medicine service and professional education provision was done by the state, but it is organized and regulated by your private professional groups rather than the government. And then you have a social medicine, study of social, economical, environmental, cultural, psychological, and genetic factor which have a bearing on your health, the so-called social medicine. Social, economical, environmental, cultural, psychological, and genetic factor. So all these factors which is bearing the health will be studying that in a social medicine. And socialized medicine, provision of medical service and the professional education by the state, but are organized and regulated by your professional group. While what is state medicine? Government expense, the free medical services to the people is so-called as state medicine. Okay, next important highlight is first country honors. First country to socialize medicine completely is Russia. Introduced compulsory sickness insurance is Germany. And family planning, fingerprint bureau, blindness control program, India. So these are the first country honors. Socialized medicine completely was Russia. Introduced compulsory sickness insurance was Germany. And family planning, fingerprint bureau, and blindness control program was India. Okay. Then what is the difference between isolation and quarantine? Isolation is separation of cases, while quarantine is separation of healthy individuals. Isolation is separation of cases, while quarantine is a separation of healthy individual. Now in a pre-COVID era, nobody knows about the definition of quarantine. So we used to say it. Now everybody knows about the quarantine. Yes or no? So now, concept of health and disease. Speaking about the concept of health and disease, health is a state of complete physical, mental, and social well-being. Very, 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 very important MCQ. What is the definition of health? The state of complete physical, mental, and social well-being, and not merely an absence or deformity. And not merely an absence or deformity is so-called as health. Okay. And what is the WHO standard of living? Income and occupation. There are three things which contributes for the WHO standard of living. One is your income and occupation. Another one is your standard of housing, sanitation, and nutrition. And third one is level of recreational and other service. So what are the determinants of your WHO standard of living? Income and occupation, standard of housing, sanitation, and nutrition, and level of recreational and other services. Level of recreational and other services. Then HDI, Indian score of HDI is 0.64, PQLI is 65, and HDI components, very, 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 very important is this table. HDI and PQLI component. Okay, they may ask you with the exception. All of the following are components of HDI except. All of the following are the components of PQLI except. So HDI, life expectancy at birth, education index, and income. Okay, life expectancy at birth, education index, and then income. Well, PQLI, life expectancy at 1 year of age, IMR, and literacy rate. Okay, what are the contributors of your PQLI? Life expectancy rate at 1 year, IMR, and literacy rate. HDI, life expectancy at birth, educational index, income. So remember, income can never be a part of your PQLI. Remember, income can never be a part of PQLI. It is a part of HDI. Okay, it is a part of HDI. You have to remember that. Okay. Then you have a Sullivan index. Sullivan index is nothing, just the life expectancy minus duration of disability. So what is a life expectancy? It is a positive mortality indicator. The amount of life that the patient can expect to live is so-called as life expectancy. Life expectancy minus duration of disability, you may get the Sullivan index. Apart from that, disability assisted life years, DALY, is so-called as years of life lived plus years lived in disability. That is so-called as DALY. Okay. One DALY is equal to YLL plus YLD. Years of life lived plus years lived in disability. Okay. Then socio-economic indicators. So mnemonic is growing unemployment depends on house and flag. Growing unemployment depends on house and flag is a socio-economic indicator. G stands for growth rate. Unemployment stands for unemployment level. Depends, dependency ratio. And housing. Flag, FLAG, family size, literacy rate, available per capita calorie, and GNP per capita. And GNP per capita. So what are the socio-economic indicators? Growing unemployment depends on house and flag. Growing unemployment depends on house and flag. Growth rate, unemployment level, dependency ratio, housing, family size, literacy rate, available per capita income available per capita calorie, GNP per capita. GNP per capita. What are the components of HDI? Life expectancy at birth, education index, and income. And what are the PQLI? Life expectancy at 1 year of age, and then literacy rate and IMR. Literacy rate and IMR. Which is the positive mortality indicator? Life expectancy is a positive mortality indicator. Okay, that is so called as socio-economic indicators. Apart from that, we're going to talk about the CFR. That is your case fatality rate. Killing power of the disease is so called as CFR. Killing power of the disease is so called as CFR, while case fatality rate is equal to total number of death due to a disease divided by total number of cases due to a disease into, and your percentile. So what is a CFR? Killing power, death by case into 100%. Simply speaking, death by case of a particular disease into 100% is so called as like a case fatality rate. The case fatality rate of rabies is 100%, yellow fever is 80%, Japanese encephalitis is 30 to 35%, and chickenpox is less than 1%. And chickenpox is less than 1%. This is the case fatality rate of the various diseases that you have to know. These are the case fatality rate of the various diseases that you have to know. Rabies 100, yellow fever 80, chickenpox less than 1%. Okay, killing power of the disease is so called as case fatality rate. Next, we talk about the epidemiological triad. So what is that epidemiological triad? Agent, host, and environment. Agent, host, and environment. I used to remember with the mnemonic of AHE. So agent, host, and environment is a component of your epidemiological triad. And then we talk about the iceberg phenomenon. And then we talked about the iceberg phenomenon. So speaking about the iceberg phenomena, we are having a floating tip. Floating tip. Floating tip is what the physician sees in the community is a floating tip. And line of demarcation is between the apparent and inapparent infection, while submerged portion is a hidden mass of the disease. While the submerged portion is the hidden mass of the disease. Very, 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 very important MCQ. So the line of demarcation on the iceberg phenomenon indicates a difference between apparent and inapparent infection. Between your apparent and inapparent inversion, submerged portion indicates the hidden mass of the disease, while floating tip indicates what the physician sees in the community is so called as floating tip. Remember, iceberg phenomenon is not shown by, I used to remember with the mnemonic of MTR Rava. MTR Rava was the mnemonic we used to remember because we have a famous brand of MTR. So M stands for measles, T stands for tetanus, R stands for rabies, and another R stands for rubella. Okay, iceberg phenomenon is not shown by MTR Rava, which is your measles, tetanus, rubella, and rabies. Measles, tetanus, rubella, and rabies. So what are the socioeconomic indicators? Growing unemployment depends on house and flag. Growth rate, unemployment rate, and dependency ratio, and housing, family size, literacy rate, available per capita calorie, and GNP per capita. And GNP per capita was the socioeconomic indicator. Component of HDI, life expectancy at birth, and you have this educational index, and then you have the income. While you have the PQLI, life expectancy at 1 year of age, IMR, and literacy rate. 1 DALI is equal to YLL plus YLD. YLL plus YLD. So far, next area is the surveillance, passive surveillance, active surveillance, and the sentinel surveillance. What is a passive surveillance? The case reports to the health system. The case goes to the healthcare system and reports something is wrong with me. That is so called as a passive surveillance, people. And what is the active surveillance? The healthcare system goes to the patient. Healthcare system goes to the patient is your active surveillance. And what is a sentinel surveillance? The identification of a missing or hidden cases is so called as sentinel surveillance. Identification of missing or hidden cases is so called as sentinel surveillance. While healthcare system goes to cases are active, while cases goes to the healthcare system is a passive surveillance. Cases goes to the healthcare system as a passive surveillance. Then you have a sequence of disease control. Speaking about the sequence of disease control, what are the important sequence? Disease control, elimination, and eradication. Okay, control, elimination, and eradication. So what is meant by disease control? Control means prevention of transmission, people. Okay, what is meant by disease control? Control means a prevention of disease transmission is so called as disease control. Okay, prevention of disease transmission is so called as disease control. And apart from that, what is a disease elimination? It is a geographical phenomenon, people. It is a geographical phenomenon. That means the absence of disease in a particular geographical area is so called as disease elimination. Okay, disease elimination is so called as absence of disease in a particular geographical area could result in the disease elimination. So India had eliminated till now 4 diseases. Okay, India had eliminated till now 4 diseases. What are they? Guinea worm, leprosy, yaws, and tetanus. Guinea worm, leprosy, yaws, and tetanus are the 4 diseases where India had eliminated till now these 4 diseases. Okay, apart from the disease eradication, elimination of organism, where you see the smallpox is the only disease which is eliminated completely out of the world, while the last case was seen in the Somalia on 8th of May 1980. While 8th of May 1980, you see the last case of your smallpox, which was in Somalia, and the world has exterminated till now only 1 disease, or eradicated only 1 disease, which is your smallpox. Okay, India had eliminated till now 4 diseases. What are they? Guinea worm, leprosy, yaws, and tetanus. Okay, guinea worm, leprosy, yaws, and tetanus. So remember, elimination is a geographical phenomenon. Eradication is an extermination of your organism, while control is a prevention of transmission. Then you have a level of prevention. Primordial prevention, inhibition of emergence of your risk factor is your primordial prevention. Primary prevention, decrease in incidence of certain diseases. Secondary prevention, early diagnosis and treatment. And disability limitation is a tertiary prevention. Okay. Emergence of risk factor inhibition is primordial. Decrease incidence of certain diseases is primary. Early diagnosis and treatment is secondary. And disability limitation and rehabilitation is your tertiary. And ICD-11, 3 volumes, 26 chapters. 3 volumes and 26 chapters with the chapter 5 and 10. 5 is a supplementary section for functioning assessment and 10 is an extension code. Okay, 10 is a extension code. So ICD-11 was that. And apart from that, there are definitions you have to remember. Disease, any abnormal condition of an organism that impairs the function is so called as disease. Any absence or abnormality of psychological, physiological, or anatomical structure or function is an impairment. Inability to perform activity considered normal for a human being is disability. Impairment or disability that leads to prevent the fulfillment of the normal individual is a handicap. Okay, impairment or the disability leads to prevent the fulfillment of the role of a normal individual is handicap. Inability to perform an activity which was considered to be a normal for human being is disability. Abnormality or absence of any of the structure or function which is not only anatomical but maybe a physiological and the psychological structure or function is impairment. Any abnormal condition of the organism that impairs the function is disease. Dis-ease, we used to call that as dis-ease. Ease means normal, dis-ease means abnormal. Okay, they may give you any one example and they may ask you what is this. disease or impairment or disability or handicap. Example type of question may be asked in the PSM, which is quite a very important, which is kind of like a 5-star to 7-star rated topic. Okay, so this prevention levels and this sequence of disease control is kind of like a 3-star to 5-star rated topic. It's kind of like a 3-star to 5-star rated topic. Then we talk about the time distribution of disease people, short term, common source, single exposure and multiple exposure, and propagated epidemics and slow epidemics are the short term ones, and periodic fluctuation, seasonal trend, which happens once in a season. For example, dengue in India happens only in the December. Apart from that, cyclical trend and long-term fluctuation, occurrence of disease over the long period of your time. Occurrence of disease over the long period of time is so called as long-term fluctuation. So short-term, periodic, and long-term fluctuation, you may see it in the time distribution of the disease. You may see that in the time distribution of your disease. So with this, we have completed your, like concepts of a health and disease, and we have completed your history of your medicine. 2 topics we have completed. Then the third topic we are going to talk about here is your epidemiology. What are the tools of epidemiology we are having? The tools of epidemiology we are having is the rate, ratio, and proportion. Rate, ratio, and proportion, where numerator is a part of denominator and multiplied by more than 100. Numerator is a part of denominator multiplied by more than 100 is so called as rate. One such classical example is your incidence rate. One such classical example is your incidence rate, where new case divided by population at risk into 1000, where we are multiplying it by 1000, and incidence rate is determined from cohort study. Another very important MCQ. Okay, incidence rate is determined from cohort study, and rate A is a part of B and multiplied by more than 100. While ratio A is not a part of B, where sexual ratio, you may call it as an example of your ratio. A is not a part of B. Sex ratio, females by males into 1000. Females by males into 1000. So where A is not a part of B. Then proportion, A is a part of B, that is numerator is a part of B, that is denominator, and is multiplied by exactly 100. And is multiplied by exactly 100 is so called as proportion. So prevalence rate is new cases plus old cases divided by population into 100. So remember a very important fact here. Prevalence rate is a proportion, not a rate. Prevalence rate is a proportion, not a rate, and prevalence rate could be determined from cross-sectional study. Prevalence rate could be determined from cross-sectional study. So rate, ratio, proportion, you have understood. So classical example of rate is incidence rate. Classical example of ratio is sex ratio. Well, classical example of proportion is your prevalence rate. Proportion is your prevalence rate. Apart from that, you have a mortality, morbidity, and healthcare delivery indicators. They may ask you like which among the following is a mortality, which among the following is a morbidity. So 3-star mugging up topic. If you are interested in scoring a 1 more mark from the PSM, then you can mug up this. So mortality indicators are crude death rate, life expectancy, IMR, CMR, under 5 mortality, MMR, proportional mortality, and disease specific mortality. While morbidity are incidence and prevalence and notification, attendance rate at OPD and health center, admissions and readmissions and discharge notes, and duration of sickness. And you have to remember that this life expectancy is a positive mortality indicator. Positive mortality indicator. Okay, so you have to remember that. So anything with the doctor and the population and nurse and bed, that is related to the healthcare delivery indicators. Healthcare delivery indicators, you can able to remember. 3-star rated. If you don't want to miss a mark from that, then you can read these things too. Okay, you can read these things too. Then there are certain important formulas. So relative risk, incidence of exposed by non-exposed is relative risk. Relative risk of more than 1 indicates positive association. Equal to 1 indicates no association. Less than 1 indicates negative association. More than 1 positive, equal to 1 no association, less than 1 negative association. Attributive risk, incident of exposure by non-exposure divided by expo. So incident of exposed minus non-exposed by exposed into 100 is attributive risk, while population attributive risk is total minus non-exposed by total. Okay. So attributive and PAR, AR and PAR differences, we use as a expo, we replace the total with the expo in the PAR. Okay. So relative risk, incident of expo by non-expo, AR, incident of expo minus non-expo by expo into 100. While PAR, incidence of total minus non-expo by total into 100. And odds ratio, AD by BC. AD by BC is so called as odds ratio. Then international death certificate, the main antecedent cause or important line is line 1C. Line 1C is the important line in international death certificate. Very, 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 very important MCQ. Okay, important line on death certificate is line 1C. Okay, important line on death certificate is line 1C. Okay, then you have epidemiological studies, where you see the preference of establishing a causality is your epidemiological studies. And the first preference is meta-analysis, while the last preference is ecological study. First preference is meta-analysis, while the seventh preference is ecological study. Epidemiological study are observational and experimental. So observational and experimental, speaking about the experimental studies, is mainly for hypothesis confirmation. Experimental is mainly for hypothesis confirmation. You draw the hypothesis and you confirm your hypothesis is right or wrong, then that is an experimental study. And for observational, we have two types of study. One is your descriptive study, where you formulate your hypothesis, and analytical study, where you test your hypothesis. So descriptive is for hypothesis formulation, and analytical is for hypothesis testing, and experimental is for hypothesis confirmation. Speaking about the analytical studies, we are having a cohort, case control, cross-sectional, and ecological. Cohort, case control, cross-sectional, and ecological. Cohort study is a forward-looking study, and it could be a prospective study or retrospective study or mixed study. And strength of association is relative risk. Strength of association is relative risk, and incidence can be calculated. Very, 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 very important. Incidence can be calculated. Okay. Examples are Framingham heart study and Dawes and Hill smoking and lung cancer. Count Brown and Dahl on RT are the important examples of cohort study. Among that, this Framingham heart study was a prospective cohort study. Why I am mentioning it as a very importantly as a prospective cohort study was one time they asked this in the MCI, not one time, almost 2 to 3 times. Framingham heart study is a classical example of what type of study was the MCQ which was asked in your FMGE, and in the options they had given us both the prospective cohort study and the retrospective cohort study was given as a 2 options. So the most suitable answers in that scenario is your prospective cohort study. Okay, so what are the things we are knowing about the prospective cohort study? One, it should be a forward-looking study. It could be a prospective, or it could be a retrospective, or it could be a mixed one. Strength of association is through the relative risk. It could be a normal relative risk or attributive relative risk or PAR, anything it could be. Okay, and you can able to calculate the incidence from it. And examples are Framingham heart study, Dahl and Hills, and Count Brown and Dahl on RT. Count Brown and Dahl on RT. RT is the important examples of your cohort study. Then you have a case control. Speaking about the case control, you have a backward looking, retrospective. Strength of association is through the odds ratio. Okay, backward looking, retrospective, while the strength of association is your odds ratio. Then you have a cross-sectional, where you can able to calculate the prevalence rate, and it gives a snapshot of the population people, because you take in a whole city, you take a part of the population or area or certain people, and you apply the studies and you conclude your hypothesis that for a whole community. So this cross-sectional study gives a snapshot of a population. Very, 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 very important. And ecological unit of study is population. Unit of study is population. Very, 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 very important. Another important MCQ. Okay. So cross-sectional, case control, cohort, and ecological. Cohort study, forward-looking study, prospective or retrospective or mixed. Strength of association is relative risk, AR and PAR. Incidence can be calculated. While case control, remember, if they are, sometimes they may confuse you with the like a scenario, and they may ask you what type of study it is. Remember, whenever they split into two groups A and B, whenever they split into two groups A and B, one who does the work and one who do not does the work, one who does the work or one who do not does the work, and they are they are finding something from these two individuals, then it is a case control study. Very, 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 very important MCQ. Okay. So blindly choose. If they are organizing into two groups, immediately choose it as a case control study. Okay. So FMGE will not ask you the very toughest question. They may, if they are like separating the participant into two groups, then immediately it is a case control study. A part of the population has been taken. It is a cross-sectional study. So prevalence rate can be calculated from the cross-sectional studies, and it can give a snapshot of a population. And unit of study in ecological study is your population. Unit of study in ecological is population. Very, 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 very important MCQ. Very, 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 very important MCQ that you should not miss. Okay. Then secondary attack rate formula, number of exposing person with the disease in an incubation period divided by total number of exposed. Number of exposed with the disease divided by total number of exposed susceptible contacts into 100% is a secondary attack rate. Okay, secondary attack rate of various diseases are important. Among the pertussis more than 90, and chickenpox more than 90, measles more than 80, mumps 86, smallpox 30 to 45. Smallpox it is 30 to 45. Then you have a bias. Any systemic error in epidemiology is so called as bias. Bias could be of subjective, investigator, and analyzer. Okay, subjective, investigator, on analyzer. Apart from that, we have one more bias called as Bergsonian bias. It is a hospital bias, people. It is a hospital bias. And bias can be minimized by blinding. Bias can be minimized by blinding. Single blinding, subject are not aware. Double blinding, subject and investigator. Triple blinding, subject, investigator, analyzer. All three do not know. Okay. So the more you blind, the more reliable the result of your study could be. More you blind, the more reliable the study could be. Okay. Confounding. Next area is confounding. Confounding can be reduced by randomization, and randomization is the heart of the trial. Very, 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 very important MCQ. Randomization is the heart of the trial. Okay, and confounding can be reduced by randomization. Bias can be reduced by blinding. Pretty straight MCQs. Okay, and apart from that, you are having a first important step in the investigation of disease. Another important straight one mark question. What is the first important step in investigation of disease? That is your verification of your disease. Verification of your disease is the first important step in investigation of disease. Okay. Then apart from that, causal association, most important criteria is temporal association. And cases in epidemiology, first case introduced was primary. Case developed from primary case was secondary. First reported case to the healthcare system was a tertiary. Okay, first reported case to the healthcare system was a tertiary. So these are the cases in epidemiology. So first case introduced was the primary, and the cases which has been developed from the primary is so called a secondary. And then you have this tertiary is the first reported case to the healthcare system is a tertiary, and a first documented case is so called as index case. What is the first documented case is so called as index case, or also known as primary case. Okay, or also known as primary case. Okay, then clinical trial phase, we have already studied that in the like a pharmacology. We have already studied that in the pharmacology. Post-marketing surveillance is phase 4 of clinical trial, where you used to read the long-term and rare side effect. Comparison with the existing drug, phase 3, efficacy 2, safety and non-toxicity, phase 1. Okay, which is a phase 1 of your clinical trials. Okay, this is all about the epidemiology, people. We have talked about the health, we have talked about the history of medicine, and we have talked about the this one, what do we call it? We have talked about the epidemiology, health and disease, and then we have talked about the history of medicine. So speaking about the health concepts of health and disease, what is the component of your HTA? Life expectancy at birth, educational index, income. PQLI, life expectancy at 1 year of age, IMR, literacy rate. Okay, Daly formula, YLL plus YLD. Okay, socioeconomic indicators, mnemonic was growing unemployment depends on house and flat. Okay, growth rate, unemployment level, dependency ratio, housing, family size, literacy rate, available per capita, calorie, and GNP per capita. CFR, killing power of disease. CFR for rabies is 100, yellow fever is 80, chickenpox is less than 1. So line of demarcation on iceberg phenomenon indicates between your apparent and inapparent cases. Epidemiological triad, host, agent, and environment. And the diseases which do not follow iceberg phenomenon are MTR Rava was the mnemonic, measles, tetanus, rabies, and rubella. And surveillance, case reported to healthcare, passive. Healthcare finds the case active. My identification of missing case or hidden case, that is a sentinel surveillance. Disease control, prevention of transmission. Elimination, which is your geographical phenomena in a particular country or particular continent. Eradication, global phenomena. India eliminated 4 diseases, leprosy, yaws, guinea and tetanus, while world eradicated only 1 disease, that is your smallpox. Last identified case was on 8th of May 1980, which was in Somalia. Level of prevention, primordial, prevention of emergence of your prevention of your emergence of your risk factor is your primordial, and then primary is prevention of disease, early diagnosis and treatment is secondary, disability limitation is tertiary. Disease means any abnormal condition. Okay, impairment means abnormality of any structure or functions which can be anatomical or physiological or psychological. Disability, inability to perform a normal activity which is considered to be a normal for a healthy individual. Okay, handicap, impairment or disability leads to the prevention of a fulfillment of a role of a human being. Okay, apart from that, you have talked about the rate, ratio, and proportion. Rate, a numerator is a part of denominator multiplied by more than 100. Incident rate is a classical example. Numerator is not a part of a denominator. Ratio, sex ratio is a classical example. Proportion, numerator is a part of denominator multiplied by 100. Prevalence rate is a classical example. Remember, prevalent rate is not a rate, it is a proportion. Okay, relative risk, incident of exposed by non-exposed. Attributive risk, incident of exposed minus non-exposed divided by exposed into 100. PAR, incidence of total minus non-exposed by total into 100. Odds ratio, AD by BC. Odds ratio, AD by BC. Important line in the international death certificate is line 1C. And you have the cohort study, forward-looking, can be prospective, retrospective, or mixed. Strength of association is relative risk. Incidence rate can be calculated. Prevalence rate can be calculated from cross-sectional study, where you can able to identify the snapshot of a population. Unit of study in ecological study is your population. Case control study, backward-looking study, retrospective study, and strength of association is odds ratio. Formula AD by BC. Secondary attack rate of your pertussis and chickenpox is around 90, while smallpox is 30 to 45, while measles is more than 80, and mumps is more than 80. Bias, any systemic error in the epidemiology is so-called as bias, and bias can be minimized by blinding, single blinding, subject, double blinding, subject and investigator, triple blinding, subject, investigator, and analyzer. Confounding can be reduced by randomization, which is the heart of the trial. First most important factor in the investigation of disease is verification of disease. Temporal association is the most important criteria of your causal association. Primary, first case introduced. Secondary, case developed from primary. And first case to the healthcare system, that is your tertiary. Phase of a clinical trial, post-marketing surveillances, phase 4. Phase 3, comparison with the existing drug. Phase 2, efficacy. Phase 1, safety and non-toxicity profile. Safety and non-toxicity profile. With this, we are completing the epidemiology section, people. Okay, very important. Okay, very important. Next area is your vaccine. So we are having a types of vaccine. It could be a live attenuated vaccine or inactivated vaccine or toxoid or cellular fraction or mixed vaccine. Okay, vaccination schedule is pretty important. So at birth, we give the BCG, OPV and hepatitis B. At the 6th week, we give a DPT, OPV, hepatitis B1, influenza B1, rotavirus 1, TIPV1 and PCV. By 10th week, DPT2, OPV2, Hep B2, HIV2 and rotavirus 2. 14th week, DPT3, OPV3, Hep B3, HIV3, rotavirus 3, TIPV2 and PCV2. By 9th month, measles, MR1 and JE live vaccine 1, PCVB and vitamin A. 16 to 24 months, DPTB, OPVB, measles 2 or MR2, JE live 2. 5 to 6 year DPTB, 10 year TT, 16 year TT2. Okay, so TT in pregnancy, if 2 months, TT1 and the TT2 will be there for 1 month apart, and a TT booster with a history of TT on 2 doses in 3 years. Then you can do only the boosters. So situation 1, no history of TT prior, TT1 and 2, 1 month apart. While if there is a history of 2 doses of TT prior in a past 3 years, then TT booster. Then TT booster. Then contraindication in vaccines. All live vaccines except yellow fever are contraindicated in pregnancy. Remember that all live vaccines except yellow fever vaccines are contraindicated in pregnancy. All live vaccines except MMR and varicella zoster are contraindicated in symptomatic HIV. Varicella zoster are contraindicated in symptomatic HIV. Typhoid vaccines are contraindicated in fever. All live are contraindicated in immunosuppression and corticosteroid. And yellow fever and cholera cannot be given together. And children less than 1 year, yellow fever, meningococcal and pneumococcal are contraindicated. Less than 2 years, meningococcal, pneumococcal and typhoid are contraindicated. Okay, remember, this is kind of like you have to remember this, people. All live vaccine except yellow fever vaccine are contraindicated in pregnancy. All live except MMR and varicella zoster are contraindicated in symptomatic HIV. Typhoid are contraindicated in fever. And live except all live are contraindicated in immunosuppression and corticosteroid therapy. And yellow fever and cholera cannot be given together. Yellow fever and cholera cannot be given together. Yellow fever, meningococcal and pneumococcal are contraindicated in children less than 1 year. Children less than 1 year. Meningococcal, pneumococcal and typhoid are contraindicated in children less than 2 years. Meningococcal, typhoid and pneumococcal are contraindicated in children less than 2 years. Okay, children less than 2 years. Apart from that, specific side effects which is related to the a vaccination. The specific side effects were Guillain-Barré which is caused by the killed influenza, and vaccine-associated paralytic polio (OPV), toxic shock syndrome, measles and MMR, shock, DPTS and pertussis, and vaccine vial monitor 3 and 4 are not usable. Okay, look at the picture. They may give you the picture and they may ask you which one is not used nowadays. 3 and 4 are not used nowadays. And speaking about the vaccines and the strains are pretty important. So vaccine BCG Danish 1331. Site of injection is left deltoid, 0.1 mg in 0.1 ml is a dilution. BCG Danish 1331, OPV P1, P2, P3, measles easy strain, mumps gerylin, rubella RA27/3, yellow fever 17D, varicella Oka strain, Japanese encephalitis Nakayama, Beijing P3, SA14-14-2, swine flu A7 California 2009, malaria, SP66, and which is a lytic cocktail, and PF25 RTS, or SA, SCO1, or which is so called as Masquerix. Lytic cocktail and Masquerix are malaria, typhoral TY21A, DPT, which is present, which is we are giving it in the anterolateral aspect of your thigh, 0.5 ml is a dosage. So strains are important. BCG Danish 1331, P1, P2, P3, OPV or IPV, Edmonton Zagreb measles, Gerel and mumps, 17D yellow fever, RA273 rubella, Oka strain varicella, Nakayama Japanese encephalitis, Beijing P3 Japanese encephalitis, California swine flu, lytic cocktail and Masquerix malaria, typhoral TY21A. Among that, so far, whatever has been asked in FMGE are Danish 1331, Easy, Geralen, 17D, Oka, Beijing P3, and California, and Masquerix. Masquerix are the things they had asked in a previous FMGE. So remember, this table is again a 5-star rated topic. So Danish 1331, BCG. Edmonton Zagreb, measles. Geralen, mumps. 17D, yellow fever. Oka strain, varicella. California strain, swine flu. Beijing P3 or Nakayama or SA 1442, Japanese encephalitis. Masquerix and lytic cocktail, malaria. You have to remember that, people. You have to remember that. Then we are having a mission Indradhanush, which was launched in 2014, where the covered diseases are diphtheria, pertussis, tetanus, diphtheria, pertussis, tetanus, childhood tuberculosis, poliomyelitis, and hepatitis B and measles. Hepatitis B and measles are the one where you have to remember. Okay. Diphtheria, pertussis, tetanus, childhood tuberculosis, poliomyelitis, hepatitis B, and measles are the diseases which has been covered in Mission Indradhanush. Then you have a cold chain. So vaccines are carried out the cold chain. Cold chain, the component, most important component is your Iceland refrigerator. For a districts, there will be a 300 to 240 liter capacity. For PHCs, 140 liter capacities, and it has to be placed 10 centimeter away from wall and requires 8 hours of uninterrupted power. Requires 8 hours of uninterrupted power. Temperature should be maintained between +2 to +8. Temperature should be maintained between +2 to +8, except yellow fever and vitamin A. Yellow fever should be extremely cold, and vitamin A can be kept at the room temperature. And based on the principle of thermocouple, we use the temperature of your ILR is measured by dial thermometer. ILR of temperature is measured by dial thermometer. What capacity for district? 240 liters. What capacity for PHC is 140 liter. Okay, and the temperature +2 to +8, except yellow fever, which is extremely cold, -30 to +5, and vitamin A, which is normal one. Temperature measured by dials thermometer. Okay, most effective sterilizing agent is autoclaving. Hand washing is the best method to prevent the nosocomial infection. 40% formaldehyde is used to disinfect biosafety cabinets, and sodium hypochlorite is used for the disinfection and sterilization of blood spill, and hot air oven is used for the sterilization of syringes and glasswares. Sterilization of syringes and glasswares. Then we are having important theories. So screening of the disease, sensitivity, person who has the disease is sensitivity, person who do not have disease is specificity. Formula is A by A plus C into 100, while specificity D by B plus D into 100. Positive predictive value, whomsoever is positive, and divided by the, whomsoever is positive divided by total positive is PPV, actual positive by total positive. PPV A by A plus B, and NPV D by C plus D. Okay, D by C plus D. Crossing, okay, crossing, or the vertical is sensitivity. Vertical is sensitivity, while crossing is specificity. This is sensitivity and specificity, while this is your positive predictive value and negative predictive value. Sensitivity and specificity. This is your positive predictive value, and this is your negative predictive value. Okay, you have to understand in that pattern. And likelihood ratio is sensitivity divided by 1 minus specificity. Sensitivity divided by 1 minus specificity. So apart from that, Bayes theorem are there, which is not important for you. So far we are done with the vaccines and the screening diseases. Vaccines and the screening of the diseases we have done. So we have done almost 30% of your, like your PSM. We have done 25 to 30%. Tomorrow we will do the remaining 70%. Tomorrow we will do the remaining 70%. So far we have done screening, vaccination, epidemiology, concepts of health and disease, and we have covered your the basics or history of medicine also we have covered. So far we have covered the important topics, people. Okay, tomorrow we will discuss about, for 1 hour, we discuss about the communicable and non-communicable and national policies for 1.5 hours. And the remaining 1 hour, we will do the remaining portions like environment and health, nutrition, and biostatistics. Every area will be covered up by day after tomorrow. Okay, every area will be covered up by day after tomorrow. So these are the important things you have to remember, and mostly try to understand the important concept, because PSM is a high yield. This lecture is one of the important lecture. If you sit for the next 2.5 hours for tomorrow, then you can master. And if you read the like a PDF again and again, it will help you to score almost like more than like a 25 to 27 question in that notes itself. Okay, quite a concise, important, covered everything type of notes. Okay, so read it in a proper way, understand it, and get it done. Okay, all the very best. We pass for today, and see you all people tomorrow. We pass for today and see you all people tomorrow. Have a nice day, people.